Right, ma'am? We are now live. Please start. Ma'am, you can start.
Good morning, everyone. So today I'm going to right. Shall I start
Yes, ma'am. You're live. You can start.
now? Good morning, everyone. So today I'm going to discuss a very interesting topic, very common condition, that is childhood urticaria. I'll try to keep it very and all the practical aspects as regard to management of urticaria in children. So the content will mainly revolve around these standard headings only. Urticaria basically is an eruption of transient edematous, pruritic raised skin lesions or dermal swellings, which last from few minutes to 24 hours. The individual lesion size in 24 hours, and if it persists beyond 24 hours, if this process is deep, then it may present a swelling of the lids, hands, or genitalia, and persists for 2. It is known as angioedema. Urticaria with presence edema without urticaria may have different pathogenesis and clinical features. So basically, this isolated angioedema, it occurs in pre-angio other than histamine. Urticaria symptoms would be present. Now, acute urticaria is usually a benign condition in children and is precipitated by infection or any other IG-mediated trigger.
Ma'am, there is some problem with the slide. The slides are not moving.
Is it, I'm on introduction slide, is it visible?
Yes, ma'am. Now it is visible, ma'am.
Slide has changed.
What is urticaria?
Introduction.
Yes, ma'am. Yes, ma'am. Now it is visible.
So maybe, yeah. So acute urticaria, it is basically a benign condition in children and it is precipitated by infection or any other IG-mediated trigger. It is a self-healing course and it usually subsides in a month. And if it persists beyond 6 weeks, it is known as chronic urticaria. So chronic urticaria is urticaria which is present for more than 6 weeks. In children, there are no clinical markers which can predict which child is going to develop chronic urticaria. However, in adults, it has been suggested that patients who have associated angioedema or who have positive autologous serum skin tests, that means autoimmune, they are likely to have more severe urticaria which persists longer. Chronic urticaria is basically classified into chronic inducible urticaria when there is identifiable physical eliciting factor, or chronic spontaneous urticaria when there is no definite eliciting factor. The terms chronic spontaneous or chronic idiopathic, they are used interchangeably. However, chronic spontaneous is preferred as anti-IG autoantibodies are also present in this. The same definition has been used by these standard most accepted international guidelines. The chronic inducible urticaria is further subclassified as symptomatic dermographism, cold urticaria, delayed pressure urticaria, solar urticaria, heat urticaria, and vibratory angioedema. And these are collectively known as chronic physical urticaria. It also includes cholinergic urticaria, contact urticaria, and aquagenic urticaria. So the point prevalence in children, it varies from 1 to 1.5% and sometimes even less. In children less than 16 years of age, the majority of them, they present with urticaria only. With few children, they present with isolated angioedema. Both urticaria with angioedema is seen in around 1/10 of children. In children less than 3 years of age, the presentation may differ, with around 60% have angioedema and 50% can have, in addition, hemorrhagic lesions. Anaphylactic shock is rare in first year of life, but its incidence increases with age. Urticaria is basically caused by increased permeability of the capillaries, for which the main culprit is histamine, but other chemical mediators may be involved, like platelet activating factor or other cytokines. The process of urticaria can be mediated by either immunological or it could be non-immunological mechanisms, also called as allergic or non-allergic urticaria. However, most of the times it is difficult to differentiate whether it is Ig mediated or not, especially in chronic urticaria. Acute urticaria is usually Ig mediated. It is secondary to an allergen, more common in atopic individuals, while chronic urticaria, as said previously, is due to non-specific histamine release, not induced by an allergen, and serum Ig levels may be normal. Non-immunological causes of mediator release include certain foods like eggs or drugs as aspirin, penicillins, radiocontrast media, physical stimuli, or heat and cold, etc. The most accepted hypothesis for the pathogenesis of chronic urticaria is that mast cell degranulation is triggered by IgG antibodies against the Ig molecules or its high affinity receptor in around 50% of the cases. In additional cases, mast cell activation and degranulation may occur due to functionally active IgE type of autoantibodies against anti-IL-24 or anti-TPO IgE. IgM and IgA autoantibodies have also been demonstrated. These autoantibodies can be detected by certain tests in vitro or in vivo. In vivo tests include ASST, that is autologous serum skin test, or APST, that is autologous plasma serum test. Positive ASST has been demonstrated in around 1/4 to 1/2 of the patients. In vitro tests are basophil histamine release assays and basophil activation tests, which are usually not available. Some forms of chronic inducible urticaria can also have these IgE antibodies against the autoallergens. In most cases of chronic urticaria, no causative factor has been found. Autoimmune urticaria can occur in about 50% of the cases. However, association is not proven with any identified causative factor which have been described in literature, as its removal or reintroduction does not improve urticaria. The main cause of acute urticaria in children is viral infections, mainly of the upper respiratory tract. Other causes include food and drug hypersensitivity in around 5% of the cases. A presumptive cause of urticaria is identified in majority of patients of acute urticaria, but it is less in cases of chronic urticaria. Viral infections are the most common infectious cause of urticaria in children, especially the acute one. Immune complex mediated urticaria is seen in pre-ecteric phase of hepatitis B, measles, mumps, rubella, or viruses like adenovirus, enterovirus, parvovirus, and so on. Parasitic infestation as blastocystis, giardia, Ascaris, stranguloides, etc. may be responsible, especially for if the patient belongs to an endemic area and serum Ig levels are raised with eosinophilia. Bacterial infections such as UTI, dental abscesses, streptococcal pharyngitis, sinusitis, etc. may also induce urticaria. Helicobacter pylori has been most extensively studied bacteria in urticaria. However, there are conflicting reports showing improvement in urticaria after its eradication. Similarly, fungal infection like Candida can also lead to this urticaria. However, treatment of above rarely cures urticaria, or in other words, role of these infections and infestations has been overemphasized in the literature. Drug-induced urticaria can be Ig mediated as caused by penicillin or NSAIDs as aspirin, or it can be pseudoallergic or due to direct mast cell degranulation, for example, due to morphine, codeine, or quinine. Some patients come with history of urticaria due to multiple drugs, when drug additives rather than drug itself may be the responsible agent. Drugs can cause acute urticaria or serum sickness-like reaction or anaphylaxis. History and chronological association with the drug intake are important clues in vitro clues, and these skin tests, they usually do not play much role in this. When caused by penicillin, it is more severe with penicillin injection. Family history of penicillin allergy is often present. Polymorphism in IL-4 gene has been reported in such cases. Beta-lactam antibiotics and cephalosporins can lead to serum sickness, while sulfonamides and tetracyclines are also the common cause of urticaria. Other drugs causing urticaria include lidocaine, corticosteroids, insulin, radiocontrast media, other NSAIDs, etc. Drugs, they do not play much role in chronic spontaneous urticaria. More commonly, they play a role in acute urticaria. However, COX-1 inhibitors can aggravate urticaria through non-immune mediated mechanisms and should be avoided. Now, food. Urticaria due to food allergy could be specific, that is caused by nuts, fish, and eggs, or non-specific as due to shellfish. It could be an immediate reaction or delayed reaction. Responsible food in children less than 15 years of age are eggs, peanuts, cow milk, fish, and mustard. In specific allergy, skin testing has a role, as even small quantity induces the severe kind of reaction. Cross-reactivity of food allergens can be seen with other non-food allergens, for example, kiwi with latex or apple with birch pollen. In this, while the food is in the mouth, the patient experiences immediate itching, burning, swelling of the tongue, and buccal mucosa. Urticaria often starts in the perioral area and angioedema can be associated. There could be other symptoms like nausea, vomiting, diarrhea, and explosive reactions. Even anaphylaxis can occur. However, this food allergy is a rare cause of chronic urticaria in children. In children with positive oral food challenge, the elimination diet does not have any role and it does not always cure urticaria. And there is insufficient evidence that pseudoallergens and vasoactive amine-rich foods can modify the course of urticaria. Now, urticaria has been described after vaccination like measles, hepatitis B, tetanus, etc. The foreign protein and eggs on which the virus is grown are the main culprits. However, children who are allergic to eggs can safely be vaccinated. Antisera may lead to severe reactions such as anaphylaxis. And physical urticarias are also important cause of chronic urticaria. These may present in isolation or any patient of CSU can have dermatographism. Dermatographism, that is appearance of wheal on stroking the skin, can occur in normal individuals or with chronic spontaneous urticaria. In some, it can be very symptomatic in the form of severe itching. It can occur in mastocytosis, which is a condition in which there is infiltration of the skin by mast cells. And here, on stroking the skin, wheal develops locally at the site of skin lesion, while surrounding skin may remain normal. And this is known as Darier's sign. It is mostly idiopathic, but rarely it occurs after penicillin intake or following an infestation like scabies. The local warming of the skin sometimes induces whealing, and this is known as heat urticaria. Cold urticaria can be immediate or delayed on exposure to physical stimulus, that is cold, and it is idiopathic. Cold bathing in these individuals may lead to sometimes anaphylaxis. Typical history given by patient in this is urticaria, which is precipitated by cold wind or after drenching in rainwater. Oral intake of cold items may lead to swelling of lips or of oral mucosa. It may occur secondary to certain viral infections or with systemic conditions also known as cryoglobulinemia or in genetic syndromes, which I would be discussing later. In systemic cold urticaria, generalized whealing occurs as reduction of after reduction of core body temperature. The local ice cube test is negative in this. It may have associated dermatographism or cholinergic urticaria. Cholinergic urticaria is a condition characterized by presence of tiny V's, which, as you can see in this picture, which leads to any stimuli which leads to sweating can lead to this cholinergic urticaria, including exercise or like sitting in front of heater, taking spicy food or emotional outbursts. It's a common form of chronic urticaria, and it is more commonly seen in winters when there is a difference in the environmental and the core body temperature. The episode lasts for 15 to 30 minutes or even longer. Spontaneous resolution may occur. Exercise-induced urticaria can be idiopathic or sometimes occur due to food sensitivity. Solar urticaria can occur with any spectrum of light. There may be an underlying condition or it may be idiopathic. Underlying conditions can be SLE or porphyrias. Contact with water at any temperature may induce urticaria, and this is known as aquagenic urticaria. So above you can see the picture of solar urticaria, and down it is basically pressure urticaria. In aquagenic urticaria, these resemble cholinergic urticaria, although they are fewer in number. Any vibratory stimulus like toweling can lead to urticaria. Delayed pressure urticaria usually occur in association with the chronic spontaneous urticaria. Patient typically gives history of developing wheals at the site of pressure, such as under waistband or on prolonged walking on the soles or after prolonged holding of the object on the hands, and it may be accompanied by systemic symptoms. These occur at the site of contact with allergen, known as contact urticaria. It can be commonly due to food or latex. Oral allergy syndrome is a form of allergic contact urticaria involving the mouth, which is characterized by immediate itching, swelling, and burning after eating a wide range of fresh fruits, including apples, pears, cherries, plums, spices, hazelnuts, etc. Eating cooked, dried, peeled, or bottled fruit does not often cause these symptoms. And this is due to direct exposure to vasoactive chemicals. It also occurs from exposure to cosmetics, which can have cinnamic aldehyde or balsam of Peru, or food additives, which can have sorbic acid or benzoic acid or other preservatives. These systemic diseases can have urticaria as one of the manifestations. Articarial vasculitis can occur either alone or in association with SLE. Juvenile rheumatoid arthritis can present with urticaria along with fever and joint symptoms. Kawasaki disease can have different kinds of skin rashes, and urticated cutaneous lesion is one of them. In diffuse cutaneous mastocytosis, there are no localized skin lesions. The patient may present only with urticaria. In Gleach syndrome, angioedema occurs along with eosinophilia and fever. In PFAPA, periodic episodes of fever occur along with cervical adenitis, aphthous stomatitis, pharyngitis, and urticaria after every few weeks, and which lasts for about few days. Leukemia, lymphomas, or lymphoproliferative disorders can lead to urticaria, but these are rare in children. Urticated lesions may occur in autoimmune bullous diseases such as pre-bullous phase of bullous pemphigoid or dermatitis herpetiformis. Then urticaria is seen in association with autoimmune thyroiditis and celiac disease in children. However, there is not much evidence that chronic urticaria in such patients have different course. Neither treatment with thyroxine improves urticaria in such patients with thyroid dysfunction. Urticaria patients are more likely to have celiac disease. However, gluten-free diet has not shown much improvement in urticaria in these patients. Urticaria can occur in association with certain genetic syndromes. These can be discussed under 3 headings: complement system abnormalities, physical urticaria, and metabolic. Under genetic complement system abnormalities, the main type is hereditary angioedema. In this, there is deficiency of enzyme C1 esterase inhibitor, and this is basically of 3 types. Type 1, in which enzyme is deficient. Type 2, its function is abnormal. And type 3 is X-linked, which basically occurs in adults. Adolescents usually have this kind of urticaria, and it is precipitated by minor trauma such as even slapping. Only angioedema is present. Sometimes one can see some erythematous lesions, but wheals are not seen in this condition, and this angioedema is painful. If it involves the airway, then there can be a breathing problem. If it involves the bowel, then patient can have abdominal pain. Low levels of complement C2 and C4 are present in this. Measurement of C4 levels in this is the screening test. Functional assays for type 2 should be done for the diagnosis. It can be acquired, but rare in children, where it can occur in association with SLE. Then all physical urticarias can be genetic. Family history is present, as these are usually autosomal dominant. Metabolic causes include mainly autoinflammatory syndromes, where one can see gene mutations, as mentioned on the slide. Various autoinflammatory syndromes are, as you can see, familial cold urticaria, Muckle-Wells syndrome, TRAPS, hyper-IgD syndrome, SINCA, or NOMID. And these syndromes are basically characterized by systemic symptoms as fever, arthralgia, conjunctivitis, urticaria, and other systemic involvement in various combinations in different syndromes. As per these international guidelines, these conditions are not considered to be types of urticaria due to their different pathophysiologic mechanism and clinical presentation, and should be considered as differential diagnosis. Cause may not be found. So this is the same slide. Sorry. So the cause may not be found in majority of patients of urticaria, and it is commonly found in acute urticaria more commonly than the chronic urticaria. The lesions resolve in minutes to hours or days in angioedema, and it leaves behind normal skin, and sometimes rarely hemorrhagic stain may remain. Wheals are erythematous, raised lesions of varying shapes, sizes, and configurations, such as annular, gyrate, serpiginous, or round. In less than 3 years of age, the presentation may differ, as there can be associated swelling of lower limbs with some bluish discoloration known as acrocyanosis. There can be cochard morphology. Hemorrhagic lesions may be present. Systemic symptoms may be seen. However, the itching is variable. Now, the timing may give a clue towards the etiology. It lasts longer in viral etiology, few days to few hours in food allergy, few minutes in cholinergic urticaria. It appears late, that is 6 to 12 hours after the stimulus, and persists longer in pressure urticaria. Anaphylaxis develops rapidly in 5 to 30 minutes and begin with pruritus and subsequently other symptoms. So this table is showing a common differential diagnosis of urticaria. So this could be mastocytosis, annular erythema of infancy, acute hemorrhagic edema of infancy, hinoxaline purpura, which is a type of vasculitis, papillary urticaria, porphyria, and erythema multiforme for urticaria. And for angioedema, it is acute hemorrhagic edema of infancy, insect bites, sometimes cellulitis can mimic this, granulomatous cheilitis, or contact dermatitis. So this is again showing differential diagnosis. So mastocytosis basically can be differentiated on the basis of that the fixed skin lesions are present, which are macules, brownish in color. Darius sign is positive. There can be systemic symptoms and systemic forms. On lab investigations, there is elevated serum tryptase levels, and the skin biopsy can differentiate this condition. Then in papillary urticaria, basically, there are erythematous papules which are present on the exposed areas, and these are persistent. Again, history is important in these patients. Then vasculitic urticaria can be with the normal complement levels or with hypocomplementemia. So in this, again, there are erythematopurpuric lesions which last for more than 24 hours. Pain and burning are more common as compared to itching, and it is associated with fever and other symptoms. And they leave behind hyperpigmentation, not the normal skin. And history and biopsy again can differentiate, which will show leukocytoclastic vasculitis. With hypocomplementemia, it is associated with SLE, and there would be reduced complement levels, especially C3, C4, and the ANA would be positive. Again, these lesions are present usually for more than 6 months, and skin biopsy is able to, we can differentiate it from the normal urticaria. Then these various syndromes, CAPS, which include familial cold, autoinflammatory syndromes, or Muckle wells, or other these cold-induced syndromes, they are usually autosomal dominant, and they have early onset, usually in the first few months of life. And the lesions, in the lesions, there is no itch. The patients can have exanthem, fever, arthralgia, conjunctivitis, and other systemic symptoms in different syndromes. Then the important thing is they show negative response to cold challenge, and diagnosis is for basically the molecular diagnosis. Now, no routine workup is required in patients of acute urticaria. History and physical examination is important in these patients. In chronic urticaria, detailed history, physical examination are important. However, based on this, one can go for basic or extended diagnostic workup. So in the history, the important points are basically frequency of the urticaria, whether it is daily or intermittent, What is the duration of the skin lesions? Wheals, they are lasting for less than 24 hours or more than 24 hours. In more than 24 hours, they basically occurs in delayed pressure urticaria or in vasculitic urticaria. On contrary, wheel lasting less than an hour are common in physical urticaria, especially in cholinergic urticaria. What is the shape, dimension, or distribution of the wheels? Linear wheels on corresponding to stroking can occur in dermatographism. Tiny wheels can occur in cholinergic urticaria. Wheels on exposed areas can occur in solar urticaria. At the site of contact can occur in contact urticaria, and at site of pressure can occur in pressure urticaria. The presence of isolated or associated angioedema, if it is present, if it is isolated angioedema, so this is more commonly seen in hereditary angioedema. Whether there is any family history of atopy or urticaria or systemic disorders. Atopics, they are usually more prone for allergic urticaria. Age at onset of symptoms is important, especially for genetic syndromes. Urticaria in less than 6 months of age, the cow milk is basically suggested as common cause in this age group. Triggering, what are the triggering factors, aggravating factors, particularly what are the food habits, medications, any association with that, any association with physical exercise, physical factors, and interval between the exposure to the wheel appearance are also important. Circumstances and places when symptoms occur, whether during day, night, inside, outside. So all these are to find out the cause or the triggering factor. Then the systemic signs and symptoms that may suggest organ or systemic disease such as celiac disease or vasculitic urticaria, autoinflammatory conditions. Whether there are any subjective symptoms as pain, burning, itching, what is the quality of life, any prior test, if these are done, then effectiveness of the present or the past treatment to decide about the management strategies, then any laboratory test should be performed basically only when history and the clinical data suggest an eliciting factor or systemic disease. Then IgE-mediated reaction to foods or drug is a possible cause of chronic urticaria when reaction develops within 1 or 2 hours after allergen exposure and subsides in few hours. However, allergic reaction to NSAIDs may occur up to 24 hours. If time interval between the allergen exposure and onset of urticaria is different, then IgE-mediated reactions are unlikely, and there is no point in doing allergy tests such as skin prick test or specific serum-specific IgE test or challenge to food or medications. Patch test which is done on the skin to foods, that is not advisable. Additives, preservatives, and color-free diet in foods and medicines is advisable only when there is any suggestion of relationship in the history. If there is improvement on such diet, then double-blind placebo-controlled provocation test is required for confirmation. Then routine diagnostic workup is done if there is no clue in the history. It includes ESR or CRP and DLC to look for any infection, IgG, anti-TPO, or total IG. The extended workup includes, based on history, avoidance of allergen, diagnostic tests such as allergy tests when the history is present, test for any infection, thyroid or functional autoantibodies, serum tryptase levels, skin biopsy, or provocation test for chronic inducible urticaria. This table is showing tests for chronic inducible urticaria. So provocation tests are done for these this thing which can be done even for sitting in the OPD. Simple tests, I'll tell you in the next slide. The DLC, ESR, and CRP should be done to rule out infection in cold provocation urticaria and also in symptomatic dermographism. Then, in cases of solar urticaria, one should rule out the light-induced dermatosis. So this is a table which is showing tests for chronic inducible urticaria in detail. So dermatographism, simply while you're sitting in the OPD, you can use a blunt object like key and just stroke it on the skin and you can see a development of a linear wheel. In cold urticaria, if basically ice cube test is done, it is applied on the skin and the results are read after 10 minutes. At the site of contact, the patient will develop urticaria. In heat urticaria, patient can be asked to sit in front of a source like heater or in a heated room. In delayed pressure urticaria, there is a standard device which can be used to check for delayed pressure urticaria. Solar urticaria, again, the patient can be exposed to the UVA, UVB, or to the direct light. Then again, for vibratory angioedema, there is vortex. There is an instrument which can be used to see the urticaria, confirm the diagnosis. Then in cholinergic urticaria, one can ask the patient to do exercise, and if the patient develops urticaria after that, so that is suggestive of cholinergic urticaria. In aquagenic urticaria, wet compresses are done with water for around 20 to 30 minutes, and then one can see if a patient develops the wheals. In contact urticaria, skin prick test or patch test can be done. So these are various tests for physical urticarias. Then regarding diagnostic approach, when there is no temporal relationship between exposure to an allergen and onset of symptoms, then there is no role of allergy test to any of the foods, additives, inhaled particles, or medication, and it is not recommended. When such history is present and IgE test is positive to that allergen, then diagnosis can be confirmed by avoidance followed by the provocation testing. Diagnostic tests for infection should be done based on history and lab investigations. Then this picture is again showing diagnostic approach, which has been suggested by the Italian guidelines, which are the only guidelines for pediatric urticaria. Although the international guidelines, IKE guidelines, have also can be used for the pediatric urticaria management. So this is based on the duration of the wheals. If it persists for more than 24 hours, so that is suggestive of vasculitic urticaria or delayed pressure urticaria. For vasculitic urticaria, diagnosis can be confirmed by the skin biopsy. If the wheel duration is less than 24 hours, then if the patient's history and physical examination suggests that the lesions are inducible, then the test for the inducible urticaria should be done. If there is any suggestion or association with the food and the drug, then the skin test, serum specific IgE or provocation test should be done. If there is any suggestion of infection, then the specific laboratory test should be done for that. In recurrent hereditary angioedema, test for complement level should be done. C4 is the basically screening test. If it is positive, then C1 INH levels can be measured and its function can be measured for the type 2. Then gene mutation analysis can be performed if there is any suggestion of any of the genetic syndromes. If all of these are negative, then differential blood count and CRP or ESR should be done. And the diagnostic test for celiac disease or thyroid disorders can be done. And in selected cases only, ASST, which is to look for the autoantibodies, can be done. So the approach would be to confirm the diagnosis by differentiating it from other differential diagnosis. Then cause should be, one should look for the cause, one should look for the triggering factors, one should look for the comorbidities which are associated, which could be autoimmune comorbidities, or it could be mental health, or it could be atopic or other allergic comorbidities. One should look for the effect of chronic urticaria on the quality of life. Then for the management aspects, one should look for any systemic association, prognostic factors, and then one should monitor the course of the disease. Then these are the various quality of life measures and various measures to see the severity of the urticaria, which are basically patients' reported outcome measures. So these are urticaria activity score, angioedema activity score, chronic urticaria quality of life questionnaire, or angioedema quality of life questionnaire. Urticaria control test can be seen while patient is on treatment and to see the response. So this slide is showing the urticaria activity score, which is done based on a number of wheals the patient is developing and done by the patient itself in the past 7 days. So the number of the wheals are counted and the patient records it in his diary. Then the grading of pruritus is also done on the scale of 1 to 3. And if this score is less than 6, then it suggests a well-controlled disease. If it is 7 to 15, it suggests a mild disease. And if the score is more than 28, it suggests a severe disease. Similarly, for angioedema, again, the grading can be used on the scale of 0 to 3 for the swelling. In the last 24 hours, at what time of day the patient develops the swelling, how severe is the swelling, whether the patient is able to perform the daily activities, and to rate the overall severity. Then this is basically showing the urticaria control test. So if a patient has urticaria, these questions are asked from the patient. So patient go through each of the question and choose an answer from the 5 options that best fits his situation. And this is basically, this assessment is done in last 4 weeks. Then the management strategies, the goal of the treatment is basically to treat till the disease is controlled and to improve the overall quality of life of the patient. The therapeutic approach is basically first to eliminate the underlying cause and the eliciting factors, and then to reduce the activity in the mast cell mediator release by various therapeutic modalities. The principle of treatment are to assess the disease, adjust, and then as needed. And depending on that, there would be step up of therapy or step down of therapy. Counseling is basically required. The patient has to understand that treatment has to be continued for a long time. Most of the time, the patient says that whenever the patient takes the treatment, he remains all right. But as soon as he stops the treatment, he again has recurrence of symptoms. So he needs to understand the disease has its natural course and he has to continue the treatment which is required to control his disease. Now, this figure is basically showing again the management decisions and the treatment adjustments. So first, you have to assess for by diagnostic procedures, comorbidities, severity by using various patient-reported outcome measures, patient preferences. Like some of the patients, they say they feel drowsy with certain antihistamines. So we have to choose an antihistamine which does not cause sedation. So we have to assess for the side effects of the treatment. We have to modify the treatment and treat the comorbidities if we detect it. We have to look at the non-pharmacological intervention, especially for the chronic inducible or physical urticarias. We have to educate the patient regarding the treatment, that treatment has to be continued. Then in adjustment, we have to step up if it is inadequately controlled and change if the side effects occur, and step down if the patient remains symptom-free for 3 to 6 months. So if the UCT or urticaria control test score is less than 12, that means the disease is uncontrolled and we need to step up the treatment. If it is 12 to 15, that means the disease is well controlled and we have to continue the therapy and try to optimize the treatment. And if it is UCT is 16, that means the patient is completely controlled and we just need to step down when the patient remains all right for 3 to 6 months. Now, so according to international guidelines, first we have to use the standard dose of second generation antihistamine. If the patient is not adequately controlled, then the updosing can be done up to 4 times. If the patient is not controlled with this, then the omalizumab has to be used, which has to be given 300 milligrams 4 weekly subcutaneously. In children, the dose is less. It is given as 150 to 300 milligrams every week. And in adults, it can be increased up to 600 milligrams every 2 weeks. If the disease is still not controlled, then cyclosporin can be considered, and starting dose can be 2.5 to 3 milligrams per kg body weight, which can be increased up to 5 milligrams per kg body weight if the response is inadequate. So these are the comparative comparative treatment guidelines, international, and these are the Italian guidelines, which are the only guidelines for management of pediatric urticaria. So one has to start, according to this Italian guideline, one has to start with the second generation antihistamine at standard dose. If the disease is not adequately controlled, then after 2 to 4 weeks, the patient can be again, if the patient is less than 12 years of age, then increase the antihistamine up to 4-fold according to the standard dosages in this age group. If the patient is more than 12 years of age, then omalizumab can be added as to antihistamine. If there is an inadequate control after 6 weeks or even earlier, the symptoms are intolerable, then both the age group in less than 12 years of age, as an add-on to antihistamine, leukotriene receptor antagonist like montelukast can be added, or omalizumab if patient is more than 6 years of age, or cyclosporin can be added. If the patient is more than 12 years of age, then again the dose of antihistamine can be done, and then again the same 2 modalities can be added. Now, these are the dosages of the antihistamine, second generation antihistamine in various age groups. So basically, disloratadine, cetirizine, levocetirizine, or fexofenadine, they can be given in more than 6 months of age, and dosages has been defined in this age group. For loratadine and for other 2, rupatadine, which is not available, it can be given in more than 2 years of age, and bilastine has to be given in more than 12 years of age. Then these are various preparations, oral solutions, syrups, and tablets which are available for these common second generation antihistamines which are used. So first generation antihistamines are preferred by some of the physicians. However, first generation antihistamines like hydroxyzine, which is commonly used, these are usually not recommended as they have more severe, more side effects as compared to the second generation antihistamines, which are safer. And they have proven efficacy in pediatric population, including bilastine, cetirizine, dusloratadine, fexofenadine, levocetirizine, and loratadine. H1 antihistamine should be given for 1 to 2 weeks, and one should look for the effectiveness of these drugs. And these are effective, then they should be continued for 3 to 6 months, and then the evaluation is done whether we can stop these antihistamines or not. So which second generation to choose? So all antihistamines have been found to be efficacious. However, few studies have shown slightly superior efficacy of levocetirizine over desloratadine and fexofenadine. All are tolerated well, and sometimes patients, they complain of drowsiness. Some patients tolerate these drugs better as compared to other patients. So if one second generation antihistamine is effective, then what to do? So in literature, there is some evidence that a different second generation antihistamine can be tried. Can we use combination of antihistamines of first and second generation? No. So as per the literature, these are not more efficacious. However, sometimes we use it. But according to studies, the efficacy is same if you use only for second generation or combination. Then combination of H1 and H2 histamines again is not recommended for pediatric urticaria. Then omalizumab, it can be used in children more than 12 years of age if it is not controlled with antihistamine. However, it has also been tried in children more than 6 years of age. A dose which is used in children is usually 150 to 300 milligrams every 4 weeks, and the response is seen as early as 1 week. Some may show late response at around 3 months, and the relapse may occur again after stopping the treatment. So this treatment also doesn't affect the natural course of urticaria. This treatment has also been tried in chronic inducible urticaria. Then cyclosporin is mainly used in children more than 12 years of age, sometimes even in more than 9 years of age. The dose is usually 3 to 5 milligrams per kg. We have been using it in other dermatosis again, but the close monitoring is required for the blood pressure and renal functions. So literature for urticaria is mainly available for adults, but it can be used safely in children also. Should systemic corticosteroids be used? So to tide over the crisis in acute exacerbation in chronic urticaria and sometimes in severe acute urticaria, it can be used, but it should be limited for 3 to 10 days and not more than 10 days in any case. And the dose which is used for prednisolone is 0.3 to 0.5 milligrams per kg body weight. Then for Montelukast, role is again not proven. There are no studies in children. However, we have seen that it can be used safely in children along with antihistamine if it cannot be managed alone with antihistamine. Zafirlukast has been used, although we are not using in this drug. Then other immunosuppressive, what is the role of other immunosuppressive as we use it in adults? So there is some evidence for the efficacy of vitamin D supplementation, or it can be done if there is deficiency of vitamin D. Hydroxychloroquine has also been used, and phototherapy, which is the PUVA and the narrowband UVB, has also been used in pediatric urticaria. However, other drugs like methotrexate, Dapsone, doxepin, biological, pseudoallergen-free diet, these have not been used in children, and there is no much evidence in the literature. Then allergen-specific immunotherapy has been tried in 2 studies, especially if there is association with this allergen. Then effects of treatment of autoimmune thyroiditis and celiac disease on natural course of urticaria. So there is no effect. There is no effect of role of allergen-free diet in patients with urticaria. Regular monitoring of psychological status is important for early detection of tension, anxiety, depression, or social isolation, or somatic complaints of sleep or eating disorders in children. Assessment of quality of life should be done in these children. In children, basically, regarding the prognosis, acute urticaria is common, which has a good prognosis. It usually resolves in around 1 to 2 months' time. 1/3 can have chronic urticaria, which may last for more than 1 year. It may last up to 10 years also. And chronic urticaria resolution rate in children is similar as that of adults, and there are a few studies where it has varying proportion of remission. So in 10 to 32%, it resolves at 1 year, 31 to 54% at 3 years, and 38 to 72% at 5 years. And the rate is around 10% per year for chronic urticaria. So there are some prognostic factors which has been suggested as good and bad. So in patients less than 19 years of age, they may have better prognosis. If there is vasopenia, they may have better prognosis. If it is autoimmune type, again, they may have better prognosis. Female more than 10 years of age with severe disease onset at the onset can have worse prognosis than some physical urticarias like cold urticaria, solar urticaria, chronic inducible urticaria, and atopics. They can have worse prognosis. If the initial IgE levels are high, that may also have worse prognosis. The natural course of chronic inducible urticaria is also like chronic spontaneous urticaria. So basically, chronic urticaria patients, they have fluctuating course with periods of remission and exacerbations. The long-term follow-up is required to adjust the treatment strategies as needed and monitor for potential complication. In general, childhood urticaria has a good prognosis. Any treatment does not affect the natural course of chronic spontaneous urticaria. So to conclude, there are more chances of finding the causative factor in acute urticaria. In majority of cases of chronic spontaneous urticaria, causative factor is not found. Around 50% of patients of chronic spontaneous urticaria are of autoimmune type. Workup should be based on detailed history and examination. Unnecessary investigation should not be done. Second generation antihistamines are the mainstay of managing childhood urticaria. Any second generation antihistamine can be used without any preference. Majority of the cases can be managed with antihistamines. It's important to remember. In antihistamine resistant cases, omalizumab can be used safely in more than 12 years of age and some even in more than 6 years of age if it is required. In antihistamine resistant cases, more than 9 years of age or more than 12 years of age, even cyclosporin can be used safely for short duration. So these are my references. Thank you so much. Thank you.
Thank you, ma'am, for a wonderful presentation.
Thank you. Thank you, sir. Thank you.
Dr. Damini, are there any questions? Mr. Das, would you like to ask something? I'll just upgrade you. Good morning, sir. Mr. Das, you can ask your question. Dr. Das? Anyway, ma'am, how long the antihistamines can be given?
In chronic cases of chronic urticaria, we usually give it, and if it is effective, the minimum dose which is required for the control of disease, that has to be continued for a minimum of 3 months. And at 3 months, we again reassess, we stop the treatment and we see whether the patient is still getting urticaria. If it is, then it has to be continued again. We have been using it for years without any problems.
Thank you. Ma'am, are there any dietary restrictions? Unless the food allergy is proven, only then we should do dietary restrictions, or anyway,
No,
like sometimes people say don't use this, don't use this.
So that is wrong. That will
Health.
affect the health of the child, especially in this age group. Dietary restriction should not be imposed unless we are very sure and the tests they demonstrate that there is some relationship with the food. So routinely it should not be advised.
Ma'am, is there any basic OPD test that we can do in the OPD?
For the physical urticarias, yes, I mentioned like simple stroking or ice cube tests can be done. And for otherwise, if there is basically the most important thing is to ask the detailed history and examination. That is the most important thing. No simple tests are required. However, in chronic urticaria, it has been suggested certain lab investigations can be done even if there is no history suggestive of anything. That simply includes DLC, CBC, and this ESR and CRP to look for any infection. And these for autoimmunity, we can just do anti-TPO antibodies. and serum Ig levels. That can be done minimum in chronic urticarias, nothing in acute urticaria.
Dr. Damini, are you there?
Yes, sir.
Dr. Anjali Gera has asked something about the exercise and heat-induced urticaria. How should we manage exercise and heat-induced urticaria?
So we can just explain the patient that he should avoid doing these things, and prophylactic antihistamines can be given to these patients. And usually all these urticarias have a spontaneous remission. So patient has to take antihistamine till he has the symptoms. That has to be continued. And we just have to avoid all the triggering, factors. That is the most important thing.
Ma'am, what is the role of immunotherapy in allergic urticaria?
Immunotherapy has not been much evaluated for this thing. It has been tried. But again, these allergens and all, you have to prove whether this allergen is responsible for this urticaria. Only then one should consider immunotherapy, right? So if there is no proven allergen, then there is no role of this immunotherapy.
Ma'am, can you please again show the slide of strength of antihistamines? You can share a slide through the basic presentation also.
Yeah.
Strength of antihistamines.
Sure. Strengths of antihistamine. Just, I'll be showing the slide.
I mean, in the meantime, what can be done in the newborn below 2 months of age? Can we use only calamine, or this is the strength of?
So no antihistamine is basically said to be safe in children less than 6 months of age. And urticaria is also rarely seen in this age group. It is very rare.
Mm-hmm.
So we have been using either promethazine or sometimes even hydroxyzine. So these are the drugs which we are using. So that is the only situation where we are preferring, H1 antihistamine to H2 antihistamine. That is the only situation.
And
yeah.
Ma'am, is there any role of anti-inflammatory along with antihistamines?
Anti-inflammatory, you mean to say that has a role, especially when the urticaria is mediated by other mediators. Not in other urticaria which is mediated by this. Which anti-inflammatory? Corticosteroids, are you asking?
Ma'am, I think non-steroidal have no role, but we can use the steroids only.
Steroids that should also be limited only for, it should not be used for more than 10 days. So that is just to tide over the crisis. Otherwise, steroids should not be used.
Ma'am, is there any role of skin biopsy?
Skin biopsy, when the wheal persists for more than 24 hours. In that case, skin biopsy can be done because that means it is not urticaria. Only urticaria which persists for more than 24 hours, that is pressure urticaria, which is delayed pressure urticaria, in which the history is very much suggestive. And the second is the angioedema, which may persist, again, which is the clinical this thing. So only for vasculitic urticaria, one can go for skin biopsy, which shows leukocytoclastic vasculitis on histopathology. Yeah.
I mean, a teenager having exercise-induced symptoms, it is okay to give antihistamines pre-exercise?
Yeah, definitely. That can be taken. That can be given. That's the only thing which can be done.
Ma'am, for how long we can use leukotriene receptor antagonist?
That doesn't have, that is used only when the patient is not responding to antihistamines. So you're giving a maximum dose of antihistamine, that is up to 4 times we can give for this age group. And if the patient is not responding to them, then you can give it. Safety, I'm not very sure. We have been using again it without any problems for around, you have to reassess at 3 months. So we have used it for 3 months, 6 months without any problems. Even longer also in some conditions like mastocytosis, we have used it. So it can be safely used.
Should we doing the allergy panel testing regularly, or there's
No,
hardly
we are
any?
not doing any allergy allergy
Okay.
panel. So that is only required when there is a strong history, and that proportion of patients having this strong history of this association is not much. So routinely, that should not be done.
Any role of patch test?
Patch test has a role only in certain drug-induced urticarias. That's the only thing. For food allergens also, one says that it should be avoided. Anyways, we are just doing it for drug-induced urticaria. That's it.
Any role of desensitization?
That has been suggested in literature. But one can do that, but routinely it is not done. Tactically, we are not doing it. But it has been suggested in literature that desensitization can be done. Like a drug is required and the patient has the symptoms of, urticaria with that. So and drug is essential. That case, desensitization can be done. For solar urticaria also, say if there is graduated exposure to the sunlight and other UV radiation, then the patient this is one form of desensitization, and after that patient remains lesion free for some time.
Is there any role of thyroxine, low dose thyroxine in autoimmune urticaria?
No, it doesn't affect the course of the urticaria itself.
Okay.
No, there is no such evidence. And
We answered most of the questions, but if there are any questions, we'll let you know. And we'll be sharing this presentation on the link in the group. And thank you very much, ma'am. Thank you for a great session. And I thank you all the delegates for joining us. Thank you, ma'am. Thank you once again.
thank you.